Welcome to a conversation on protecting rights of children with medical complexity in an era of spending reduction. My name is Rishi Agrawal. I'm an associate professor of pediatrics at Northwestern University Feinberg School of Medicine and a pediatrician at Lurie and Lara Vida Children's Hospital in Chicago. Today's discussion features one of the articles from the March 2018 issue of the Pediatrics Supplement entitled Building Systems That Work for Children with Complex Healthcare Needs. The articles in the supplement feature writing from leading healthcare providers, family representatives, advocates, policymakers, and researchers. The hope is that these articles will help to clarify some of the difficult systemic issues and challenges affecting healthcare for these children and point the way toward their resolution. Today's conversation is hosted by the Lucille Packard Foundation for Children's Health. You can access all the articles in this series and stay up to date on future conversations by visiting their website, lpfch.org/AEP supplement. A few housekeeping items before we begin. We want this to be a lively discussion and encourage attendees to ask questions. You can submit questions in the GoToWebinar question box. All will be muted for the duration of the webinar. A recording of the webinar and all the slides will be posted on the Foundation website and shared with all registrants via email. Now I'd like to introduce our panelists for today's conversation. We are pleased to welcome Jane Perkins, Legal Director of the National Health Law Program. Jane is one of the lead authors, along with me. I was very honored to co-author this with Jane, entitled Protecting Rights of Children with Medical Complexity in an Era of Spending Reduction. Jane will review the article's key content and discuss what government and private healthcare plans are doing and should be doing to promote optimal health for children with medical complexity. Jane has extensive experience bringing enforcement action to promote services for this population. Joining us today are two great experts in the field. I'd like to welcome Dr. Jeffrey Goldhagen, Professor of Pediatrics at the University of Florida College of Medicine, Jacksonville, and the President of the International Society for Social Pediatrics and Child Health. Also with us is Dr. Edwin Simpser, President and CEO of St. Mary's Healthcare System for Children. Welcome to you all. We will start the conversation with a few words from Jane.
Good morning or good afternoon, everybody. Thank you so much for having me. Next slide. As Rishi mentioned, I am going to be talking about the importance of insurance coverage, both private insurance coverage and Medicaid coverage, and also the importance of enforcement. I can state the overview of child status in a couple of sentences because you all know it well. There are hundreds of thousands of children with medically complex conditions, and research shows that over half of them have unmet health care needs. We know that this is though it's a small percentage of the Medicaid population, for example, it is a population that represents a very high proportion of Medicaid expenditures. Next slide. So talking just a little bit about private insurance coverage. When I say private insurance, I'm talking about employer-sponsored coverage, policies that individuals purchase, and policies purchased through the Affordable Care Act marketplace. And there are some rights that are set forth in the Affordable Care Act. A couple of them are listed here. The first is the requirement that states cover 10 essential health benefits that are listed there in the statute. The two that are most relevant here are pediatric oral and vision coverage and rehabilitation and habilitation services. The Affordable Care Act, Section 1557, also has for the first time ever an anti-discrimination provision that prohibits healthcare entities, including insurers, from discriminating on the basis of race, color, national origin, disability, sex, and the like. The thing about private insurance that is notable is its variation. Even with the Affordable Care Act's 10 essential health benefits, there's quite a bit of variation from one state to the next because each state gets to set its own benchmark for coverage of these 10 essential benefits. Moreover, states have mandated benefits, and these vary significantly from one state to the next. A state may have mandated insurers to cover ABA therapy services, for example, if they want to sell products within the state, but the very next neighboring state might not have that mandated benefit. Another feature of private insurance that's a limitation for children with medically complex conditions is that they typically are limited in terms of their coverage of long-term services and supports. Next slide. So that brings us to Medicaid. Medicaid is a publicly funded health insurance program that extends coverage to low-income children. There are many doorways through which children can access the Medicaid program. The ones most relevant here are that their incomes are below 133% of the federal poverty level, and they're below 18, or they're children with disabilities. What's significant about Medicaid is that it entitles children to coverage of early and periodic screening, diagnostic, and treatment services. We call it a benefit because it's more than just the state sitting back and waiting for payment when and if a claim is submitted, and the following slides will explain that. Children and youth under the age of 21 years old are eligible for and entitled to EPSDT, just like children are entitled to a public school education. Next slide. So the basic requirements for EPSDT, as its name implies, are early and periodic screening. And these are 4 different types of screens. Medical, which includes what we call 2x3 lead blood assessment. By law, children on Medicaid are supposed to get 2 lead blood tests before the age of 3. The medical exam also has developmental assessment, health, education, and anticipatory guidance, and other aspects of a checkup for a well child. There's a vision screen that includes eyeglasses when necessary, hearing assessment that includes hearing aids when necessary, and dental assessments that include relief of pain, restoration of teeth, and maintenance of dental health. One of the things that we have noticed at the National Health Law Program over the years in the advocacy that we do is that in states there's a tendency to see EPSDT as a screening program. And these 4 components will receive attention, but the DT part does not. And it is equally important for children. Next slide. So the treatment part of EPSDT has 2 components. The first is a scope of benefit component. And under the Medicaid Act, all services that can be covered under the state Medicaid plan for adults must be covered for children when they're necessary. As you all, I'm sure, know, they're both mandatory and optional services for adults. And so the services that children are entitled to include case management services, in-home skilled nursing, also called private duty nursing, home health aides, personal care aides, medical equipment and supplies, physical, occupational, and speech therapy, respiratory therapy, rehabilitative services, and transportation and related services. Related services include the cost of a caregiver or an attendee to accompany a child to a healthcare visit, including food and lodging if needed. That's one that we don't think a lot of states are implementing. This is a comprehensive list, and the things that children with medically complex conditions need that aren't on this list and that aren't part of EPSDT would be 3 things: habilitation services, home modifications, and respite. Many states have waivers, home and community-based waivers that cover these services for at least some children in need. Next slide. So the second part, in addition to setting forth a scope of benefits, the Medicaid Act also includes a definition of medical necessity for children, and it is services that are necessary to correct or ameliorate physical and mental illnesses and conditions. So ameliorate means to keep from worsening. It doesn't have to cure it. Another critical component is that the state Medicaid agency must arrange for corrective treatment that the child needs, either directly or through referrals. Next slide. As advocates, what we have done is to marry, if you will, EPSDT with disability rights or disability laws. Particularly the Americans with Disabilities Act and Section 504 of the Rehabilitation Act. These laws contain an integration mandate, which requires entities to ensure that qualified individuals with disabilities are living in least restrictive settings, not hospitals, for example, not step-down units, for example, if they can and want to live in less restrictive settings. These laws also prohibit entities from having standards, criteria, or methods of administration that have the effect of discriminating on the basis of disability or that perpetuate discrimination. An example here would be, and this is taken from a Seventh Circuit case, where a state has similarly situated children. They've come in through different Medicaid doors, and for some reason the state's paying providers higher rates to care for medically complex children who come through one door than it is for children who are in the same situation who have come in through another. Where there's a violation, the remedy is a reasonable accommodation, such as a rate increase in the example that I just gave. Next slide. So over the years, there has been not a great deal of litigation considering the violations that can happen out there because litigation is very resource intensive, but here's some examples. Obie versus Norwood is a case out of Illinois where the court, as affirmed by the Seventh Circuit Court of Appeals, required the state Medicaid agency to arrange for in-home nursing services for children with medically complex conditions with reasonable promptness and to ensure coverage of those services in the least restrictive setting. The state was arguing that it needed to pay claims when claims are submitted, but it need not take these additional affirmative steps to get the program out to children. Rosie D. versus Romney is a Massachusetts case that requires coverage of support services for children with serious emotional disturbances, including crisis intervention services and in-home behavioral supports. The next couple of cases I think are interesting because they are getting at issues that are around the fringe of the commonplace, but that do happen nevertheless. Radishewski versus Merrim is a case where, citing the Americans with Disabilities Act, the court said you need to continue, the state Medicaid agency need to continue covering the in-home services that this individual with a medically complex condition needs, even though they've turned age 21 and they've lost access to the EPSDT benefit, and ordered the state to go assess what reasonable accommodations the state could make to make sure that the individual was able to continue receiving services in their home. And there have been a few cases like that over the years. And then the last case that's mentioned here is Salazar versus District of Columbia. And I included that one because that's a case that we've done, and what was happening there is that decisions were being made about coverage for children with medically complex conditions, and the decisions were being made by managed care organizations based on clinical guidelines, in this case the McKesson guidelines. And when we wanted to dispute the denial of services and asked for the guidelines, the state and the managed care plans and ultimately McKesson refused to turn them over, saying that they were trade secrets. And so we brought a case, an enforcement action within this existing case to require disclosure of those clinical guidelines, which the court did indeed require. Next slide. So that's my presentation. I'm happy to answer questions about how litigation has worked and anything else you might want to ask me about. So thank you.
Great, thank you, Jane. So we're now going to transition over to Jeff Goldhagen, who's going to talk a little bit about his thoughts about the article and give his perspective. So Jeffrey, over to you.
Great, great. I really appreciate it. And Jane, thanks for a great presentation, and to the Packard Foundation for bringing us all together. So I'm told I have 8 minutes, and what I'm going to do is spend my 8 minutes really talking about a primer on what a rights-based approach, or what it means to protect the rights of children with medical complexity. And so I think the innovative aspect of this session really is defined in a sense by the title of the webinar. So it's not a conversation on entitlements of children with medical complexity. The title of the webinar is Conversation on the Rights of Children with Protecting the Rights of Children with Medical Complexity. And by using the term rights, then it reframes the whole dialogue and the whole context of the discussion. If I had written the title, I would have said, called it Conversations on Fulfilling the Rights of Children with Medical Complexity. And the talk that Jane gave was clearly something that's necessary in order to do it, but not sufficient. So if you go back then to really unwrap and unfold what that means to protect or fulfill the rights of children with medical complexity, then we reframe the context and we reframe the dialogue and discussion to look at a rights-based approach to what we're all really very committed to. And the first step on that journey of developing a rights-based approach then is to go back to the principles, standards, and norms of children's rights. That in turn brings us to the UN Convention on the Rights of the Child, which for those of you who are not familiar with the convention, is the only universally ratified convention, human rights convention that we have, except for the fact that the U.S. is the only country in the world that hasn't ratified it, but we have signed it. And it doesn't mean that, in fact, we can't use it. So that if you unfold the articles within the convention, if you look at the articles within the convention, there are 40 articles, substantive articles, that define the protection, fulfillment, and participation rights of children. And so from our perspective, from my perspective, in order to protect or fulfill the rights of children with medical complexity, then we have to consider all the rights that are included in those 40 substantive rights. And so that is, in fact, one of the critical principles of a child rights-based approach, and that is that no one article takes precedence, and no one article can be fulfilled and implemented without considering all of the other articles in the convention. And so that's referred to as the interdependence principle, so that in order to fulfill one right, you have to fulfill all rights. And when we look at the context of a child, the life of a child with medical complexity, we go far beyond the need to provide acute medical care or even chronic medical care in and of itself, to really looking at all the other elements that go into caring for these children. And so one of the ways that you can look at the convention is to divide it up into protection, promotion, and participation rights. And so if we look at just unfolding and looking at and dissecting participation rights, that really requires giving children a voice and to listening to them. It requires them to have access to information. It requires privacy and a whole host of other rights that are intrinsic to the convention that are required in order to fulfill the rights of children with medical complexity. Another key principle of a child rights-based approach is that children aren't the objects of protection, but the subjects of rights. And so it's not as if our role as physicians or our role in the framework of protecting their rights is our goal. Our goal really is meant to be and should be ensuring that they are subjects of rights and that all the rights that are due to them are fulfilled. If we look at 4 core rights or 5 core rights within the convention, the first is the Article 2, which is the right of non-discrimination, and Article 3 is the right to have children's best interests considered. And certainly when we're thinking in terms of children with complex medical conditions, Article 3 then opens up a whole host of questions that we need to ask ourselves and answer in the context of what are in the best interests of children with medical complexity, how are our decisions made, and with the consideration of what children's best interests are. Article 6 is the right of children to survival and development, and survival and optimal development. And so that places a burden on us as, in the sense that amongst the key stakeholders in the health and well-being of children with medical complexity, how are we advancing their medical, how are we advancing their developmental outcomes? And then the 4th key principle, or 4th key right, is the right of children to have a voice and to be listened to. And so in the context of framing how we approach fulfilling the rights of children with medical complexity, we have to go back to not only the convention and not only the interdependence principle, but also our key role in what in a rights-based framework constitutes us as duty bearers. So reframing who we are from being physicians to reframing ourselves as duty bearers with a duty to fulfill all of the rights of children with medical complexity who are referred to as rights holders. There are several other key frameworks, the Sustainable Development Goals, the SDGs. There are 17 Sustainable Development Goals. And within the context of the SDGs, there are 5 or 6 that relate specifically to children, and one that speaks directly to child health. Within the framework of also adding social justice and health equity to the context of addressing children with medical complexity, we need to really think in terms of social justice. And social justice, when you boil it down, is really how we choose to spend our limited resources. And so that really speaks to the second part of the title of the webinar, that is in an era of limited resources. So that takes us to a social justice issue. And then, of course, health equity, which is giving these children and families, but in particular children, the optimal opportunities to reach their full potential. So certainly Jane's presentation was critically important. It speaks to the entitlement of EPSDT and Medicaid. It speaks to what is necessary in order to fulfill the rights of children to optimal health and well-being, in particular children with medical complexity. But reframing this work in the context of a rights-based approach allows us to expand our roles and functions, turns us into advocates as duty bearers with the responsibility to fulfill the rights of these children, and provides, I think, a significant amount more gravitas to what our roles and functions are. And I'd just like to end with one brief comment, and that is, if you look historically within our community and within our country at what we hold dearest to us, every social movement that I think we would claim is important in our history, whether it's civil rights or voting rights or women's rights or gay rights or animal rights or victims' rights, all of them came into force in a sense by adding the term rights at the end of it. Except obviously children's rights. And so by reframing our work in the context of a rights-based approach, I think will provide us a foundation and framework and platform that's far stronger than we've had in the past. And that's my story, and I'm sticking to it, and appreciate the opportunity to present this perhaps a bit of a different perspective on who we are and what our roles and responsibilities are as physicians. Thanks.
Okay, thank you, Jeffrey, so much for your presentation. Now we're going to get another reaction from Dr. Eddie Simpser. So, Eddie, over to you.
Thank you very much, Rishi, and thank you to the Packard Foundation for putting up the whole symposium and the articles, as well as this particular webinar, and inviting me to comment. Just to frame where my perspective, my organization is in New York City, and we provide post-acute care to children, both inpatient, day patient, and home-based care. And so I'm coming at this from the perspective of a provider of services to kids with a close relationship with lots of families. And I guess I'm going to be outlining some of the issues that we experience in trying to deliver services to medically complex kids and trying to help families get the kind of services that by right they ought to be getting and the kids ought to get. So I think my first thought was to discuss why some kids are not getting, and many kids, frankly, are not getting the services that they, by right, they ought to be able to receive. And Jane already mentioned the variability from state to state in how they meet EPSDT mandates and also how they mandate insurance coverage. She mentioned that in passing somewhat that some insurance coverage is limited. Well, frankly, we find that practically all commercial insurance coverage is very, very limited when you try to provide post-acute care to medically complex kids, whether it's in a facility or whether it's in their home. In fact, some kids can barely get a few weeks worth of nursing or rehab services in their home based on their insurance. And if their state is not as progressive, let's say, as New York, where there isn't an easy transition to Medicaid for those types of patients, they really are going to struggle to get services once their insurance runs out. In a state like New York, where the counties share in some of the cost, not just at a state level, but there's services that are provided through the counties, there's even variability from county to county, and sometimes parents have to move from one county to another, or in our region, sometimes parents move from state to state in order to be able to get services. And that's clearly a burden for families. One of the other issues that we find is that the staff that are at state agencies and certainly at insurance companies, including the physicians, do not understand this population. And some kids fall between the cracks of multiple state agencies, developmental disability side versus healthcare side, et cetera, and there's rarely coordination between state agencies. And then, and I'm going to touch on this a little bit further later, but the lack of data or evidence base for this population is clearly a hindrance for us as we try to obtain services for patients. And then, despite, I'm in New York, where Medicaid has been expanded, there's extensive Medicaid services for kids, and yet the lack of adequate reimbursement makes staffing an enormous challenge. And this already it's a challenge to find qualified therapists and qualified nurses to provide care to this population. When you layer upon that a severely inadequate reimbursement structure, it makes it almost impossible for families to be able to provide care, which is why I have a bullet point called My Kingdom for a Nurse, because the lack of private duty nursing we see as the single most challenging issue in this population. And I've heard that echoed from my colleagues throughout the country. In fact, to the point where that lack of availability of private duty nursing, because of the lack of reimbursement and because of the lack of qualified staff out there, is actually forcing children to remain in hospitals or remain in a post-acute institutional care and not be able to go home. The article talks a bit about legal action that parents can take, and I just wanted to point out that if you're a parent of a medically complex child, there's enough burden just being able to care for that child. Finding time to take legal action to get the services that your child deserves is an enormous challenge. And then even after the courts rule, the issues related to finding appropriate staff remain. And it was interesting to read in the article the comments about the courts trying to force states to take action on their own to find services for children. And certainly our experience in New York is that the state defers that work to providers and case managers and others, and rarely do we ever see the state agencies themselves getting involved in finding services for kids. And I think that one of the concerns that I have is that there's virtually no federal oversight on states. There's no federal oversight on whether they're meeting EPSDT standards, whether their mandates for insurance companies are meeting the ACA, as Jane pointed out, and you rarely hear about the federal government getting involved in this level of care, in this level of service delivery. And so it really is a bind for families when they're trying to get services and being able to find the right people to advocate for them when they need the services for their kids. I mentioned previously that there's a lack of evidence-based data. And I think that for me, one of the messages that came out of this article was that it's incumbent upon us in the field to try to develop this data. I have an idea of how many nursing hours a particular patient might need, but convincing a payer or convincing a physician reviewer at a state agency who doesn't understand the population and telling them that they need X amount of hours of nursing services because I have that expertise and I know they need it just isn't enough. We need to have evidence. And until we have that evidence, we're going to continue to struggle to try to get services for our patients, for these children and their families. And then we probably need to develop standards of training and expertise for the staff that are going into kids' homes or providing services within facilities for these children as well. And I think that's incumbent upon us in the field to try to develop some of that. Also, the idea of risk-based payment structures was touched on in this article, and I've struggled, and I think many of us struggle with the whole concept of value-based payments in this patient population. How do you determine value? What are the outcomes that you're striving for that are going to bring quote-unquote value? And where's the evidence to manage some of these outcomes? And I think it's incumbent upon us as we move into these alternative payment systems that we should take the lead in trying to develop those kind of the evidence that we need, and try to develop some of those systems for value-based payments. I think I've used up my time. I have more to say, but hopefully it'll come out in the discussion, so I'm going to stop right here.
Great. Thank you so much, Eddie. That was fantastic. And all of the panelists, thank you so much for your insights. So now we're going to move into the Q&A. We've gotten some questions, but please, all of you in the audience, feel free to submit your questions to the question box. We'll get to as many of them as we can, and if we don't get to them, we'll answer them after the webinar. So Jane, I'd like to give you a chance to respond to some of the issues that were brought up by Jeffrey and Edwin. In particular, I'd love to hear your thoughts about a rights-based approach, and what you see how you see that playing into our actions. And then, from what Eddie had brought up, would like to hear some of your thoughts about, how families are able to get the wherewithal to bring action, because you've been involved in some of these actions in some states, given all of the responsibilities they have. And then also Eddie brought up some issues about federal oversight. I'm wondering, since you wear a lot of policy hats, whether you could talk a little bit about your, any reaction you might have to some of the issues that were raised, these ones and any others.
Sure. I think that in terms of, as a lawyer, when I use the word rights, I'm talking about enforceable rights in court. I thought Jeffrey's comments were so helpful because as I translate those as a lawyer, what he's talking about is advocacy policy, or how in my mind I translate that is we need to be engaging in policy advocacy to take rights that are contained in things like the UN Convention on Rights of the Child and turn them into laws that will create rights here. The UN Convention isn't enforceable in United States courts. That just hasn't had a good enforcement track record. Interestingly, Justice Kennedy was someone who was a little bit intrigued by it, but he's not there anymore. So I think that we certainly see as lawyers the rights that we are working with, and they're the ones that I summarized in my slides, they're way beyond what adult Medicaid beneficiaries have, but they are limited. There's no doubt about it. So I think that advocacy to broaden rights, and while being ever mindful of protecting the rights that we have, is extremely important. In terms of Edwin's comments, everything. I was shaking my head vigorously during much of his comments and remarks. I do think that families who work with us on these cases, who are plaintiffs in these cases, are incredible. We represent the plaintiffs in OB versus Norwood, and are along with a litigation team representing these families. And we also are in Salazar. We certainly work to make, our goal is to not make life more difficult for a family that is a plaintiff in an action. It's to make life as easy for them as possible, and to intrude in their lives as little as possible to efficiently get what we need. But we are providing pro bono legal assistance to them. If we win the case, we'll certainly ask for attorney's fees at the end, but if we don't, there's no guarantee that we will get them. But certainly the aim here is to make their participation be as stress-free as possible. I do think that federal oversight is, it has over the years been reducing. Even during the Obama years, I remember a case that we worked on at the U.S. Supreme Court where a number of past HHS secretaries came in and filed an amicus brief talking about how funding for them to engage in enforcement had been going steadily down over the years. And certainly we see now that the attention paid to enforcing EPSDT standards, or really looking into confidentiality laws, it's just not there. I think there's some actually excellent people in the administration working on EPSDT matters, but they're really viewing, and as did many in the previous administration, the role is stressing kind of the partnership between the state and the federal government, and partnering to do X, Y, and Z, or to and to try to encourage states to do things through that partnering approach as opposed to an enforcement approach. So certainly the role of families and advocates is critical here because it's needed to fill that gap that the federal government will not be filling.
Thank you, Jane. And just one quick point of clarification. When you mentioned attorney's fees, you know, if you win a case, are those paid for by the families or are those paid for by the state?
The state. Part of the law that that entitles you to attorney's fees if you're the prevailing party is the idea that the fee is part of the remedy that the state must, you know, engage in because it was engaging in wrongful acts. I guess it's part of the cure, part of the punishment, for lack of a better way to put it.
Right. Thank you. So I want to go to a question from the audience. We had a question about the trend towards large Medicaid managed care organizations getting involved in care and restricting access to needed services. For example, brand name medications not on a formulary, ambulance services may be restricted, etc. And so I think this speaks to a broader issue of, okay, we've heard about these rights. What can we practically suggest to providers who see violations of those rights all the time and it's impacting the care of their patients? What can or should we be doing about that? So, Jane, I'll ask you to first comment, but then I'd love to hear Jeffrey and Edwin's perspectives as well on that question.
In the litigation and enforcement activity that we engage in, we partner very closely with physicians and other healthcare providers. They are absolutely critical to getting relief for families and children. So I would, you know, we work with we're a National Support Center in Health for Disability Rights programs in each state. We work very closely with legal aid programs in almost every state. And we also have relationships with large pro bono firms that will contribute their resources. So where you see violations underway, if you contact us, we can try to do something about it. We have litigated on this formulary issue. We've litigated where plans and what they call case managers, we would call them utilization reviewers, are coming in and putting monetary budgets on the amount of services that a child can get and making families come within that budget, which is not legal. We've challenged that. So I think that there's just a number of the pressure to, with a per member per month payment setup can be really severe in terms of trying to make it profitable. That's one reason there's, I think, in many states, a lot of movement in and out of the Medicaid market and other markets for that matter by managed care companies. So that's what I would say. Please contact us. We can put you in touch with, either work with you directly or put you in touch with very experienced disability rights advocates in your state who work not only in the courts but in the other branches of government as well.
Great. Jeffrey, would you like to comment as well?
Yeah, for sure. And again, appreciate these opportunities. Well, one of the things that it's always difficult to talk in terms of a rights-based approach in the U.S. is that it is, at least at this point in time, more theoretical and more ethereal than real. If you go to other countries, and that would be every other country, but in particular high-income countries, the translation of these rights into reality happens on a daily basis. And so what Jane had said was right on. The only thing that I would add is that, in fact, from a rights-based approach, it's not our responsibility to fulfill the rights of children. It's the responsibility of us, meaning society and stakeholders, to provide parents with the capacity to fulfill their children's rights, and to provide children themselves the capacity to fulfill their rights. So in this context, then, the people who need to be out in front, dealing with the legislators, dealing with policymakers, dealing with the insurance companies themselves, are children. They need to have a voice. They need to be listened to. They need to be the key participants in the dialogue and discussion and the advocacy. And in other countries, the role of the children's ombudsperson, which is an independent entity whose role and responsibilities to ensure children have the capacity to fulfill their rights, is a critical role or critical position that needs to be implemented. We've implemented it here in Jacksonville on a local level. But the ombudsperson is the person then that can help ensure that children and youth have the capacity, even kids with severe and significant complex medical conditions. When the Convention on the Rights of People with Disabilities was developed and came into force after the Convention of the Rights of the Child, actually a close friend of mine was the person that was responsible for developing the articles that had specifically to do with children. She brought children with significant disabilities and complex conditions from all over the world to New York to generate and to present to the General Assembly. So this is a long way of saying that it's really critical for us to engage the voice of children and youth with medical complexities so that they can advocate for themselves, and in many respects will be far more powerful advocates than any of us, and them advocating in collaboration with their families as well.
Eddie, would you have some thoughts on this subject?
Sure. So I think if you look at Table 1 of the paper, it discusses the applicable protections for children with medical complexity, and almost in all cases it's state mandates. And certainly kids who are enrolled in a Medicaid managed care plan, the oversight of the services provided by that plan fall to the states. And so we have found that we are at times, at least in New York, there is an appeal process that allows us to work at a state level to try to get appropriate coverages and services for our kids. And I think it is important, as though the population of medically complex kids expands within Medicaid managed care plans, as was mentioned, the plans have to understand what these kids are going to cost so that they can negotiate appropriate per member per month payments in order to cover what are mandated services. But I find that we need to take this to the states to force them to oversee the managed care plans to provide the appropriate services.
Great. Thank you to all of you for that. Now I have a question that was directed perhaps more to Jeffrey about the child rights based approach. One of our audience members asked, how do we determine who should be leading the plan of treatment, especially when providers and families are intimately involved? At what point do we determine the individual is competent from a clinical developmental standpoint to make informed decisions on their treatment? So, I was wondering, Jeffrey, if you could comment a bit about the role of families and providers, when thinking through the lens of a child rights-based approach.
That's a wonderful question. And so within the 40 articles of the convention, 11 of them speak directly to the critical role and responsibility of families in fulfilling the rights of their children. So the convention is not anti-family and anti-parent by any means, which is sometimes what more conservative organizations and individuals suggest, but rather it's very much pro-family. And Article 5 of the Convention speaks directly to that and frames that in the context of a child's evolving capacities. So that first and foremost is to provide the child the right to a voice and to be listened to within the context of their evolving capacities. So so that is one role that we as health professionals can play, is to really represent children and youth, give them the opportunity to speak, and to be able to comment on those evolving capacities. Now, that is somewhat of a political and cultural definition. In the Netherlands now, children have the right to euthanasia. Obviously, there are some protections, but they have the right to terminate their life based on their medical conditions and their wishes. And so we would say in the U.S. that no child has that capacity. In the Netherlands, their community and their culture says, well, for sure they do. So the critical article in answering that question, or beginning to enlighten us on that question, is Article 5, which speaks directly to the evolving capacity of the child, and Article 3, which talks about best interests, allows a community to make a decision considering the best interests of the child and considering the voice of the child. It doesn't mean that all decisions have to be made based on what the child wants, but at least those best interests need to be considered.
Great, thank you. So Eddie, some questions now directed to you from the audience. There was some discussion about your ideas about the need to develop evidence for service delivery for this population. And there were a couple of comments. One, given the variability between individuals with different conditions, is evidence for types or levels of care realistic? That was one question that came up. And then another related one was, who should be responsible for conducting the research for developing pediatric criteria? Should it be the federal government or CMS? Is it something that individual states should regulate with pediatricians on their medical boards? And I think this speaks to the broader issue of, we see a lot of state variation in terms of what a given type of patient might receive in terms of services, and there's not much evidence. So I was wondering, Eddie, if you could, give some thoughts about what you think would be a good path forward to improve the situation.
And so those are great questions. I think that if it was simple to develop evidence-based, we probably would have done it already. There are plenty of us in the field taking care of these kids. So I do agree that it's a challenge to go forward and to do that. And I'm heartened actually by the recent funding of a group, if I could put a plug in, for a project funded by HRSA to develop a research agenda for children with medical complexity. Chris Dill and Jay Berry are leading that group. Rishi is actually one of the committee leaders, and a number of us sit on that group. And I think that hopefully out of that grant, and we will come up with opportunities to try to develop some of this evidence-based data that can help us in terms of getting kids services. For now, I see that as the first step forward. I do think that clinicians involved in the field can take some initiative on their own as well. I think in addition to that larger group, and I would just encourage folks to be thinking about the field and how we can develop appropriate evidence for the care that we're providing.
Okay, great, thank you.
Can I comment quickly on that?
Yes, please, go ahead.
Yeah, so, again, we come down to the question of who we is, right? So, so in a general context, CBPR, a community-based participatory research framework for answering that question, I think, is critically important. It ought not to be we, right? If we means physicians and we mean professionals alone, for sure. The we ought to be children and families. And although, you know, it may arguably be not exactly the same, I go back to the AIDS epidemic, and the we was physicians, and then the we became due to a really very radical voice that was forced on us by the people living with HIV and AIDS. They became the critical entities that define how we spent our money and how we defined outcomes and so on. And out of that came Ryan White and a host of innovations. If we fast forward 30 years, that's the kind of radical rights-based voice that we need to hear, not just from the physicians, but from the children and families themselves, for them to define for us what the critical outcomes are. And I can tell you that if you ask children and families what those outcomes are, the medical aspects of it are only a tiny part of it. These people, they live their lives out in the community, they live their lives in schools, they live their lives in lots of other places, with that they would see also as critically important in many respects as what we do in the health system. And so I would argue, I'm not part of the group, but I would argue, if not already implemented, that a CBPR approach drive this effort to identify these outcomes and indicators and evidence base.
So, Jeffrey, I think we all agree. And in fact, I think if you take a look at the physician population that serves medically complex children, you will find the most family-centered individuals available in medicine, I believe. And the group I mentioned and the grant that I talked about involves families from the beginning, and they're involved at the table and are critical to any of this work. And I totally agree with you that this is, I believe that physicians have to take the lead and move this forward, but partnership with the families and many of the outcomes are quality of life outcomes, not necessarily clinical, pure clinical outcomes. I totally agree with you there as well.
Great,
oh, and I would just add that children themselves need to be critical parts of the elements of the families that are working with you as well.
Thanks to both of you for wonderful reaction, and thanks to Jane for her wonderful presentation. We have to wrap up, unfortunately, which is it's unfortunate because it's such a great discussion, but we're a little past time. So, take heart that we're going to be answering your questions after the webinar. So stay tuned for that. Thanks to everybody for attending. Our next discussion will be a conversation on ethical considerations for a fair and effective healthcare system on October 24th. Registration is now open, so please visit the Packard Foundation website for all the details. And a recording of this conversation, the slides, will be sent to all attendees, as well as we will be answering remaining questions. We are always looking for ways to make these conversations more engaging and welcome your feedback, so please be sure to complete the survey that pops up at the end of the session. Thank you to all. Thank you to our panelists. Thank you to our audience for really making some really great questions, asking great questions and making this lively. And have a wonderful day. Thank you, everybody. Goodbye.
Thank you. Bye.